My name is Jess Pawley and I'm a knowledge and evidence specialist with the quality improvement team in Somerset FT. And I'm also part of the evidence for QI team as well. And I'm stepping in for Andrea Gibbons this morning, who's currently away. And I'm here just really to introduce the session and just a bit about E for QI for those of you who aren't aware. It's been going for a few years now and is a programme designed to sort of bring improvers and libraries and evidence, that's where I come in, together. And really the whole purpose of these spotlight sessions is to bring you all together and connect with other teams to find out what others are doing outside of your own organisation, and to just build those connections. And that's all about what QI is, isn't it? Just finding out what others are doing, how can we use it, how can we improve what we're doing as well. So that's the main premise of E for QI, and these spotlight sessions have been going for some time. We've got a few more lined up as well, so there will be publicity coming out about those shortly. But today's session is I'm going to get this right, is the Solent Academy of Research and Improvement at Solent NHS Trust. Okay, and today I've got with us, just checking, I've got Sarah Williams, Carl Adams, Helen Wareham, Anita de Havilland, I hope I've said that properly, and they're going to share with you their story of QI by stealth, which really appeals to me, and their programme of work on demand and capacity, as well as work they've done around patient and public involvement and engagement. So as I say, we will take some questions either partway through or at the end, depending on how the team want to manage it. But what I'll do now is I'll stop sharing my screen and I'll stop talking, and I will hand over, I believe, to Sarah. So thank you.
Morning, everybody. I'm hoping I'm presenting our slides. That was slideshow. So thanks for joining us. It's always a bit weird, isn't it? The morning after a very sunny bank holiday, you crawl back into a dark office. But it's nice to see you now. I can't see you. So we've got other members of the team who are monitoring the chat, and obviously Jess will be as well. So we're going to talk about our programme of quality improvement and how it fits with other things in Solent. Do ask questions as we go along, and we're going to test out stopping for questions after each section, so you don't have to listen for an hour, which most of us find quite hard to do, I think, these days. So we are a community and mental health trust down on the south coast of England. We cover Portsmouth, Southampton, and then big chunks of Hampshire and the Isle of Wight as well for certain services. So we're very lucky. We live in a very nice area of the land.
Please, can I ask anyone to go on mute if they're not presenting? Thank you.
That's better. Okay. So we started our quality improvement journey, I think it was 2016, and it started very much as a programme. But what we were quite keen on or insistent on was it became one of a suite of tools for improvement as part of sort of growing a culture of learning and improvement across our trust. We're slightly unusual, and you'll see that we're Academy of Research and Improvement in that we have an integrated approach, and we have a team that supports all sorts of different areas of improvement and learning and innovation across our trust and beyond, actually. So we have a QI programme and training programme, but that's also linked to research, it's linked to innovation. We do a lot of audit and evaluation outcomes. We also have a knowledge specialist, so a library service within our team. And underpinning all of it is working in partnership with people, patients, people who use our services, but also community organisations and other people who work across the areas in which we work. And we do that really deliberately so that anyone who sort of wants support to improve or to test things or to problem solve or do some diagnostics around things that they're struggling with only have to come to one place in the organisation, and then we can help them with the right tools or the right combination of tools to lead that improvement. So it is quality improvement, and we do look at that. We use the model for improvement as our basic model for that, but it's a much broader offer, which is it's just about sort of culture and support and facilitation for projects to happen out in services. All of us who work in QI will have seen the NHS improvement approach that's recently been published, and some of us were lucky enough to hear the lady from NHS England who has developed this talk about this. And it was good to hear that it was all about an approach as opposed to a unified method, and it was around continuous improvement. And I'm going to try and link what we're doing back to this. So we're by no means perfect, and we've got a long way to go, but we have worked really hard at facilitating other people and skills and capacity building across an organisation, rather than being a team that goes out, and to link very much to organisational priorities increasingly. So the programme itself has lots of facets. We keep struggling with a diagram that works. And it's grown over the years from something which was a team-based training programme to all sorts of different offers, which will be suited to different types of people, depending on what they want to do, how much time they've got, their experience, so on and so forth. So there's everything from an hour's introduction, and this is taken from our annual report. So this is how much we did in the year 22-23. Across the academy, so the numbers underneath are kind of a year's work. So there's an hour's introduction, which people come along to. Often they'll go on to do what we call our foundation, which is a sort of a 1 day or 3 morning online course. People who want to do a small scale project and are very much beginner. So there's some training and theory, and then there's a lot of do a small project and learn as you do. The kind of next stage, or the sort of bigger projects, are done through a 6-month facilitated program, which we call our practitioner, and that's teams of people, always, or unless there's a very good reason why not, including patients or people from other community organisations who will be impacted by changes on that course, and that runs over approximately 6 months, and a project, a QI or an improvement project, will be done during that. So there's facilitation within the actual training days. Always face to face now that we've come out of COVID, because it makes a massive difference to people's ability to concentrate and to get some headspace and to learn from each other. So if you're on Teams, we find people are not always 100% in the room, and always as a team approach. Around that sits a load of workshops. This year you'll be hearing, we've also introduced something called Happier Working Lives in partnership with NHS Elect, which is a QI methodology, and it's all around helping people to feel very much in control of how they change their working environment and working life. And that's where the QI by stealth comes in. I suppose it is QI, but it's not called QI. And it's been really successful, because we've had loads of different sorts of people come along to that. We've had many more admin teams and so on and so forth who are a part of that, and we've got some of our patients working alongside us delivering that as well, which is fantastic. We also have a QI leader, which is similar to a QI coach program, I suppose, and those are very much embedded out in services, and we have a network of 30 staff and 2 patients leaders on that. A couple more patients now, really, but it depends how you want to label them. But so they will sit out and do facilitation or advice or signposting and QI projects themselves, and we found that that's been really, really helpful in supporting work out in services, as opposed to keeping it in a corporate team. We do things for junior doctors, for preceptors. We've started working with our performance team on waiting lists, and you'll hear about demand and capacity work that we've done. Anita runs a QI cafe, which is like a drop-in on our trust Zooms at lunchtime, sort of regularly. We've got our website. We do lots of bespoke with support, and we have online resources as well, both on our intranet and our internet. So it's meant to be a kind of make it as easy as possible for people to access, make it very much about culture, make it very much about improvement. And remember, around that sits a library service, so people can look up existing evidence and support to share their work, All projects have a one-page summary which is shared. We have a conference that sits there so people can do it, and we have sort of regular improvement forums as well, which are sort of run, and people come and present their work. And at the end of the practitioner programs, we try and do a celebration event where people can present, and we get people from other areas in as a way to share learning, because across a community organisation with 140 odd sites, it's really hard to share all the work that's going on. And I think in the last year there was somewhere in the region of 200 projects, so obviously difficult to share those. And I think across the whole academy we probably touched, through training or projects or bespoke facilitation, over a quarter of our workforce, which was great. It's great to see it recovering that well. There's a little bit more detail here on the leadership aspects. So our QI leadership program is very much around training, but also networking. So the deal is that they come together 4 times a year, and they design the program as it goes on. So they ask for the training that they want, but they also troubleshoot together. They support each other. They get additional training, and a lot of that is around leadership, not necessarily QI methods. And that's been sort of really successful in really pushing the kind of culture of improvement across the trust. And we try and work beyond our academy and beyond our organisation. So have a number of community partnerships, joint posts. We're doing participatory research around improvement, working with voluntary organisations, and starting to look at how you would measure impact or do improvement projects within those. And we do a little bit of national advocacy as well around improvement methods that are fit for purpose in community and across integrated care settings. So I could pause if there's any questions now. I know I've whistled through that at speed about our integrated approach, or we could move on. I don't mind. I don't know if there's anything in the chat because I can't see. Jess?
There's nothing in the chat, Sarah.
Okay. Are there any questions? Oh, there is a question.
We've got a hand up. Let me see.
Ronald.
Yeah, hi. It's, can you hear me? It's Ron here. Ron here from Raw Free London. Thank you for this really helpful presentation and some similarities with some of the things we're doing, but I think much for us to learn as well. Just in terms of your QI leaders, so we're having another bash at that because we've had a bit of a hiatus. We had some things in place just prior to pandemic that have not really restarted that. How have you found engagement amongst your senior leaders? You mentioned you have kind of 4 sessions a year. Can you tell us a bit more about, I guess, what the format of that is and how you keep them kind of energized and attending?
So, well, they're very self-motivated. So we have a fairly loose application process, and it's usually people who are interested in QI or who've gone through the QI program. They come and they do like a 3-day training, but over, I can't really think right now, probably 4 or 5 months. And that's very much around leadership and how it fits together. But then they have the existing network of QI leaders who also come together for a network event 4 times a year. Early days, fewer people turned up, but now they all turn up because they recognise that it's really valuable time for them. We take them off site. They do a lot of work together. They are the ones that choose what training they want to do at the next session. So we've done some stuff on systems thinking. We've done stuff on demand and capacity. We've done some stuff on happier working lives. And they design and they work a lot with us on our strategy. So they are the people out in our services that do it. And I think because we focus a lot on leadership, not on technical skills so much, and we do try and make it quite fun. We work with NHS Select as well, who help us. So we have an external organisation who are very good in that space, and it's just a nice day, I think, and people are turning up now because they can see. I think if you focus also on what has come out of it, so what projects have they managed to get off the ground and how are people in their own services starting to listen to them, it's quite self-fulfilling, and a lot of personal attention and a lot of momentum. I hope that helps. Maybe we can send across the sorts of things that we've been doing with them.
Yeah, that's really helpful. Thank you. And just out of interest, I mean, how sort of senior is a somewhat kind of open term. How senior are your senior leaders, out of interest?
So they're not. We don't. We have a mix. It's not done on seniority or band. It's enthusiasm, and we would really want a range of people who would have sort of different spheres of influence. So it's not you have to be a senior leader by any means. No, just and all sorts. People from corporate, people from out in services. Anyone who wants to give it a go, really.
Yeah, thank you, actually, and that was my bad. I put in senior. I don't think you put that anywhere. So it's leaders. So but what I'm hearing there actually is it's a range of, I guess, seniority. You're not banding it as such, and actually you're covering different disciplines and different settings in your organisation.
Yeah. Great. Go with the willing. Go with the ones who want to do it.
Absolutely.
Yeah.
Okay, there is one more question in the chat. If you want to answer it now, would you rather move on to the next?
I'll quickly answer it and then we'll move on. I can't see it though. Could you read it out?
That's fine. I'll read it out. So it's from Preeti Poligari, and she is asking about the joint sort of partnership posts that you showed on your slide. Could you please give an example of such a post and which external organisation has jointly funded this?
So we've got a couple of partnerships. So the one, so in Portsmouth, for example, we have a sort of umbrella voluntary services organisation is called Hive Portsmouth, and we have a joint post in there. We've funded that in the first instance, and the deal is that we will jointly go for grants and then we will share that income. So that's how we will match fund it longer term. The benefit is that we now can work in partnership with and think about different improvement methods with lots of community organisations, and they can link back into our service delivery. So yeah, the Hive as well. And we've been working with the Young Foundation on participatory research, and they're looking for other opportunities as well. And we work with care homes as well, quite a lot of care homes. Because we're an integrated approach, it makes us much easier to manage a budget and to fund things that are innovative, because we have our research income, and we have been doing some training at universities on QI. So we are income generating a little bit, which has made it much easier for us to be flexible about some of the work that we do and a bit more innovative, rather than being given a trust budget and finding it quite difficult to stick with it. So yeah, bundling up and finding pots of extra cash is quite helpful. Gives you more autonomy as well. Right, should we move on? I hope that helps.
Thank you, Sarah. Thank you.
So if we move on to Anita now, who's going to talk about the happier working lives that we've been working on.
Hi everybody. My name's Anita Havland, and I've been at Solent for about a year now, working predominantly in QI, and I'm a nurse by background. So we've been running this programme for just over a year. And Sarah, if I can get you to hit the button, please. So happier working lives. I just love the programme. I'm so enthusiastic for it. But some of the figures and the reasoning behind it is that everyone is entitled to joy at work. We should all feel happy coming into work. Happy team, happy patients. But some of the figures around it, and I think you can all read these on the slides, but the one for me is about companies with happy and engaged employers have 70% fewer safety incidents, which is exactly what we're all about. We don't want any of our patients to come to harm. And if we can create a happy working place that will reduce that, then it's a win-win. Staff aren't coming to harm, and we've got happy staff, which also helps with recruitment and retention. Next slide, please, Sarah. So one of the things we cover during Happier Working Lives, and when I say we, I mean the Royal We, NHS Select do a lot of the facilitation, and as an academy we support outside of the programme for anything at all that people need, whether it's helping them set up an MS Forms, a survey, creating a video, writing a blog. We do the whole caboodle. But one of the things that we go through is the hierarchy of wellbeing needs at work, which was created by Sonia Sparkles. And so we ask people and where they are their basic needs being met? Because if the basics aren't being met, you're never going to get to the top of that hierarchy of well-being. And we found, you know, within Solent sometimes that people haven't always had access to water. So those are things that we've rectified. There's been a lot of conversations about toilets. So we're kind of naming it Toiletgate. But we have been in and got toilets fixed and giving people the permission that they can raise these concerns. So it might seem trivial, but when people are sort of head down working, they've got their tunnel vision, they just don't have that headspace. So I'm going to move on, and I'm going to make it a little bit interactive now. So if you've got your phones, if you could please scan and take a really quick questionnaire around the hierarchy of wellbeing needs. In a minute.
Yeah, I'm just going to give them.
So we'll give you a few minutes to get logged on.
Is that working for people?
Yeah. I was diligently checking it this morning.
Is everybody on it? So I can go to the live responses, do we think? Anyone still not got on that wants to?
Go for the live responses.
Oh dear. I got a new laptop on Friday. That's not very good. Okay, I will stop sharing whilst you share.
Is it not working?
No.
Okay, hang on. Let me get the presentation out. Oh, it won't let me.
Oh, we're meant to have live results. Can anyone get them up?
If you can't, if they won't, we can share them afterwards. If you're able to do them afterwards and share them around. Or if you've got a link for the chat, that would be good. But if not, we can do it afterwards. Just to take the pressure off you.
There we go.
Solent, we're all in the process of, we've just had an IT provider change and we're all in the process of getting new laptops. And it's not all seamless.
No, never is.
We keep finding things that don't work, like today.
There's nothing come through on the chat. I don't know if you have posted anything in there. Oh yes, it's coming now. Yep, that's me being impatient. There we go. Okay.
All right. But we'll carry on. Sorry about that.
That's fine. Would it be helpful if I opened it and shared it? Would that help you at all?
Yeah. Does it come up?
It's doing something. Oh no, it's asking for it's asking for a login.
Oh,
no, possibly not then. Okay.
It's fine. This morning it all worked perfectly, but it just goes to show that IT issues happen at absolutely any time and the worst times sometimes. But what I wanted to highlight is whereabouts you guys were on that hierarchy and what you could do to move yourself further up. You know, are there any pebbles or boulders that you can address easily? Or not? Do you need to escalate any concerns? So it's just to get you thinking about that. Sarah, next slide, please. So really, this is when the QI by stealth comes in, and it's about giving people a different perspective on QI. So the title of the programme is Happier Working Lives, and within our flyer, we do you know, talk about that it includes QI methodology, but the way
we've lost sound. You all seem to be muted.
Is that better?
That's it. Yeah.
Okay. So I don't know where I got up to. Anyway, so yeah, so we're looking at QI by stealth. So all throughout the programme, we are talking about different ways of improving happier working lives, but we're also introducing the model for improvement. We're also looking at some of those diagnostic tools. So we do a lot around fishbone diagram, driver diagrams. But after each session, we're giving people kind of homework to go away. So we're getting them to ask those questions around what matters to you. Are people having a mostly good or a mostly bad day? So it's giving them that baseline data to come back to day 2 with, that we can then start looking at measurements and what their data means. And then at the end of that day, people then go away with ideas in to put into action. And then on day 3, we just share and celebrate some of the good things that have been done. Next slide, please, Sarah. So some of the initiatives that we've done around happier working lives. Now Sarah's having technical difficulties, I think, as well. So some of the initiatives that have gone in. So as I said, it's not rocket science, some of these things, but it's giving people the headspace. So we had one of our admin teams that were getting a lot of emails going to individual people about undertaking work, and sometimes it was work that they couldn't do. So then it was delaying the work that was happening by, you know, by when the admin team person read it and then forwarded it to someone else, and then someone else read it. So what they came up with was a generic inbox that all requests go to, and then that is checked regularly. And then the right job goes to the right person at the right time. But they've also built some resilience in within the team, so that if anyone's off sick, or if anyone's on annual leave, someone else can pick up that work, and we know that whatever we send through will get done. They also have a meeting once a week, so that if they're unsure of anything, they can discuss it through with each other and reply to that person accordingly. Also, a couple of our inpatient areas. So some had introduced a wellbeing huddle. So what was preventing them from doing their job, if anything, that day, how they were feeling, and also a communication board. So you know, any key things that were going on the ward, any new starters, any wellbeing initiatives going on, any trainings that staff now felt that they were being kept informed. And then research team spread out across many sites and felt that they didn't always know what each other were doing. So they've now arranged a monthly meeting for everyone to catch up and discuss what they're doing. And then what was really good was that one of the matrons who did the program, she was given dedicated time, or has been given dedicated time, to look at the ethos of happier working lives within their service line and how they can improve the working lives of their staff, which is absolutely amazing. But as I said, some of these things, they aren't rocket science, but it's given people that headspace to be able to think about things to make things better. But we've had some amazing feedback, and I think one of the best for me is that someone who said that they had more of a negative mindset, it's now been changed to more of a positive one, and that people didn't really know what they were coming into, and that actually it surpassed all of their expectations. So we continue to build on that feedback. We're also starting to look now at how we can really capture the benefits of happier working lives, and I'm planning on doing some follow-up meetings with the guys that have been through the programs to find out that continuing improvement and impacts of the program. So we've got that as evidence. And then with each of our programs, we have one of our side-by-side members, and I'd like to introduce you to Mary via video, if it works, around why she enjoyed it.
Yeah, we've got no sound on that one.
Right now, Sarah.
When you share screen, there's an option to share sound as well. If you're unable to get it to work again, we can send this round afterwards.
Yeah, it will be in the slide deck, and it does absolutely work on the slide deck.
So I'm going to suggest we skip on because we're getting a bit over time. Okay.
I'm going to talk to you about people participation. So my name's Carl Adams, and I support how we evolve patients throughout, because we're really keen as an academy that we put patients and people and the people who use our services at the heart of what we do. So I want to talk to you about how we do that as an academy and how we support that across the people who interact and we help. Next slide, sir. Is it working? Slow, isn't it? So get a slide. One of the things we're really keen about is actually giving people the opportunities, but actually starting with people right at the beginning of all our programs. So it's throughout what we offer, we talk about patients first off and foremost to everything. So Sarah's talked already about our QI program, or Happy Working as well. So patients are encouraged and supported as part of the service improvement. And what we love about this is that they don't just be part of the program, they come and attend the QI programs, be part of the teams from day one and come to the training. So that environment where they're learning about QI and being part of the project teams that are trying to make the change is a really good environment. So we support that, and we help the teams who apply to the program to ensure that they access and approach people to be involved. We also have the research development program, which is a bit like QI Stealth. It's a bit, given the opportunity for clinicians and to get involved in research and develop a culture of research in their department as well. And we have patients involved in that as well, who are advocates of that and help kind of bring that patient voice around if you are designing research. Our workshop programs, and if we do bespoke work, we have patients either co-deliver our programs with us, and we've really increased that over this last year, which has been amazing, and what they bring to the team and what we've really grown together then, because they have got to know what the academy is about and what we're about, and together we're able to enrich our programs by having them, but then also the people who attend get firsthand to ask questions and ask them about what it's like being involved and the difference it makes. So we bring that patient voice into the room. We've also, our services are in service lines or divisions, and they have an annual review where they go through and look at what they're going to plan for next year around audit, evaluations and improvement. And we've been able to support having patients in the room and help with that prioritization, ask those questions. Does it really, what's this mean to patients? What difference is it going to make? And really start that beginning of the planning across all our services to get that patient voice, but also then support advocacy around going and seeking further voices from different services as well. And then to aid this, we've created toolkits and resources online on the website that help these discussions and thinking and planning involving patients in access right through to approach, and importing those missing voices, those voices that are seldom heard, and those people that the improvements will affect the most. We've underpinned this with a payment policy or guide towards reimbursement to really recognise the value and support of people involved, but also to help overcome barriers around travel to get people involved as well. And that's been really helped as a trust to talk about recognition as well and reimbursement. And then the other way we're doing it, we're helping spread involvement is recruitment and interview. So thinking about that whole recruitment journey from the beginning of writing a job description right through to actually induction day one, and thinking about, can we bring the patient voice to be actively involved in that? And so we had some real sort of front runners and the willing in the trust, and so we co-designed this sort of toolkit together on our website, looking at the reasons whys and then some practicalities around forms and consent with our human resources colleagues to help spread that. And what we've learned from that, we do that as well for recruitment, is that some excellent skills and out in our community partners and with the patients who have some great skills in doing interview and recruitment, which has really helped our recruitment process. And what we've learned is that staff who want to be applying for these jobs really see the patient centeredness of that approach and have taken a job based on that notion as well. So we've really, throughout our program, keep driving for that patient involvement. Next slide, please, Sarah. This is a busy slide, I appreciate it, but we try and live and breathe what we promote. So we have a group called Side by Side Network, who are patients who work with the Academy of Research and Improvement. So they're a core group of 18 people who currently work with us on our program. And what I want to demonstrate in this slide here is that this has taken many years to grow and build on, and we started with their involvement with a few key people involved in designing our conference, and that led to forming this group as Side by Side. But although they co-design and co-deliver what we do as an academy, the offer, what they also are as an advocate for working that way. So they're side by side with us to be that voice as well. And as you can see by this, it's grown and grown, and they've got more involved in different things. We were one of the first trusts to be patients included accredited conference. So that role, how is it meaningful to patients, but actually is applicable for patients, and the lack of use of jargon and the way we present things at our conference. And that has grown. And like I said, we are really then heading towards real co-production and co-producing what we do moving forward. Does anyone have any questions around about involving people? You're going to move on, okay. Thank you.
There's no questions in the chat, but we can take some questions at the end once the presentation is finished.
Okay, Helen, everyone, I'm Helen Wareham. I'm just going to take you through the last section, and that is exploring some of the work that we have done just over the last year around integrating QI with demand and capacity and improving demand and capacity management. So why are we doing this? Well, it will be something that accords with everyone in their organisations, and it's to do with waiting lists, which have been particularly hit by COVID. So they're increasing. We have a demand capacity imbalance, and we need to find ways to manage this because we know it has a negative impact on services, patients, and staff. So the first piece of work was a pilot study where we looked at integrating QI with demand and capacity modelling. And the approach taken was to start with clinical pathway mapping and key concepts workshops. And the key concepts were around demand and capacity and key principles. We then provide guidance for actually working to produce some demand and capacity models, and the models are actually predictive forecasting models, so quite technical. But alongside this, as we worked with services, we were constantly looking for areas for improvement. So how could they improve flow? How could they improve demand management? How could they improve capacity management? Been working with a number of services across the trust, as you can see from the list here. It's very much about having a collaborative team. So the teams have operations or business managers on them, clinical leads, admin staff, and a lot of input from our performance team analysts. And all of this work has been done alongside the national demand and capacity team at NHS England, because the two models that we've been using are not published. They are still currently under development. So part of the work has also been testing and supporting development of the models for NHS England. The impact of this pilot study has covered two areas. The first, the modelling. I think one of the key things is it's enabled services to feel in control of their data and to understand it and improve their data quality. But also for the ones where we have actually managed to produce models, they've been able to actually have an evidence-based understanding of their demand. They have a clear understanding of the capacity. They understand their waiting lists, their sustainable waiting list sizes and backlog clearance. So they're able to look at these things in a much more evidence-based and informed manner, and then use that to generate improvement activities. Next, please. There's also been a lot of impacts. I'm waiting for Sarah to move the slide on, but I think I can remember, around things like optimizing clinical capacity. So some of the services, particularly looking at improving triage efficiency and effectiveness, that comes up frequently. Things like optimizing flow, so understanding variation, and then starting to actually plan for that variation and the impact that it has on their demand and capacity. Lots of things around managing demand, so reducing DNA rates, reducing failure demand. That's come up quite a lot, where there are processes within a service which are not working as effectively as they could be. Next, please. And the other thing outside of this programme is the programme that we've been evaluating is providing bespoke service support. So this has consisted of offering a whole day workshop to whole services. And it's been focused on looking at improving weights, flow and demand and capacity management. So the days have been very intense, very busy, but we've enabled services to understand key demand and capacity concepts. They've worked specifically in those days to find areas where they can make improvements. And at the end of the day, they've come up with lists of improvement activities. And then there's follow-up coaching. And the kind of things that we've been looking at is reviewing service criteria, developing clinical care pathways, improving discharge planning, implementing patient tracking lists, and actually looking at how we help patients to wait well whilst they are on those lists. I'm very much focused around actually improving waiting list management. And some of the services are working on looking at specific activities. Triage, I mentioned before, that comes up a lot. Understanding now how they can try and work to match capacity to demand for that activity. I particularly like this quote that I've put here. This is not a short-term piece of work for any service, but this person has fed back that actually they know this is a long-term piece of work to get those waiting lists under control, to bring them down, to understand how to manage things more effectively, but they feel that there is light at the end of the tunnel. And I think that was a really, really important comment. So going forwards, we're just looking at how we can build on the momentum that we've achieved so far. There's increased conversations in the trust around demand capacity and demand capacity management, increased appetite to look at this work, continuing to work with NHS England on the modelling, and just working now on how we build this programme going forwards.
So thank you. We've got a little bit of time for questions. I think we picked out 3 examples of things that we've been doing outside of our normal QI projects and training program. I hope helping a little bit to demonstrate that kind of different approaches to enabling people to do improvement in their own areas with a bit of structure, a bit of evidence, rather than being an isolated QI approach. So any questions?
We have got one question, which I'll read out for you. Thank you, everyone, for the presentation this morning. And oh, we've got a hand up as well. So I'll do this question and then we'll go to the hand up as well. So what's the one thing that you think is the key to making this work? And what is the one thing you have done that you'd advise others against?
So the key is to flex around the project and the people that you're working with, I would say. So not have an off-the-shelf, come do our training, then good luck. And to work very much alongside patients. So to distribute talent, skills, capability out in services and to bring a bit of fun to it. The thing that we did catastrophically wrong at the beginning, I would say, is this was launched at the same time that CQC were turning up for their big inspection. So we got our brand really wrong early days because everyone thought it was being done just because of CQC and they couldn't really be bothered to turn up. So don't do that. Get your brand right. Rachel.
Great, thank you, Rachel. Yep, thank
you. Hi, many thanks for that, Helen. I'm really interested to know, obviously, I think QI is absolutely vital when working alongside local teams and trying to address the certainly the backlog and the elective care capacity that we're struggling with at the moment. What barriers have you come across with that, or have you come across any with working alongside them?
I guess that's one for me. I'm being looked at. Obviously, we're community, which makes things slightly different. The biggest challenge for us has been people's time, but also data and accessing data and actually having our data is not as reliable as we would like. So we've had to make a lot of assumptions, do a lot of extra analysis. I think acute probably has less of a challenge in that area.
But I was thinking more in terms of, so yes, I think data is something that we all find a challenge in trying to do quality improvement, but certainly from clinician buy-in with this, because obviously you have to have the clinician buy-in for this. How have you come across any barriers specifically with clinicians buy-in with QI?
But for this particular piece of work, no, but then it was a pilot. So I did the recommended thing and I went out to my trusted allies. So the teams that I've been working with, and Sarah made this point earlier, I think, is go with the willing. So for this pilot, I've gone with the willing, who have been really keen, really engaged, very enthusiastic. The main challenge is that they have focused on the modelling. They want that predictive forecasting tool. And it's only now that we've created the models that I'm managing to turn them to think more about the QI and the improvement work that they can do to support that situation.
Okay, that's really helpful. Thank you.
If I could just add that because we've done that pilot and there's evaluation and now we've got advocates, we have a quite substantial waiting list of people wanting that help because we have a proof of concept. So that's helped.
Yeah, that's great. That's really good. Thank you. Because I think it should underpin absolutely everything we do, but doesn't always necessarily. We're often a bit late to the party sometimes with these things.
Okay, got 5 minutes left. Maybe got time for one more question if anybody has any questions. If not, can always follow up with the team afterwards. As I say, this has been recorded and will be made available. And the slides will be shared or will be via the video as well. So, okay, we've got actually one comment in the chat. I'll just have a quick look at that and see what that is. Oh, just a thank you. So if that's everything, I'd just like to say thank you again to the team for presenting this morning and for persevering through the tech as we all have to do. Yeah, as I say, if you do have any questions afterwards, you think you don't want to ask them in front of everyone else, do follow up afterwards. But otherwise, thank you very much for attending, and hopefully we'll see you at the next one. Thank you.